Please take your seats. Welcome to the last session of PSH 2022. Assalamu alaikum. I am Dr. Najmusahar Saeed. I am consultant gastroenterologist, hepatologist working as assistant professor in DHU Teaching Hospital, Gujranwala. I don't agree with Professor Graham in saying that this is the bitter end. They say that the best part of the book is the last. So this is the last part of the book. So for this session, we have beyond NASH and viral hepatitis. I would like to call upon the chairs. First of all, Professor Dr. Colonel Shakil Mirza. He is an ex-professor from Army Medical College, Rawalpindi, and he has been an active executive member of both PSH and PSG. And currently, he is the Vice President of Pakistan National Heart Association. So, sir, please take your chair. With him, we have another gem from the twin cities of Islamabad and Rawalpindi, and that is Dr. Shahid Shehzad Riaz from Shifa International Hospital, consultant gastroenterologist, hepatologist. And lastly, we invited someone from the city of the Lahore to accompany them, Associate Professor Dr. Aftab Haider Alvi, consultant gastroenterologist, hepatologist from Fatma Memorial Hospital. Sir Aftab. Okay. So, to start with the session, basically it is और भी गम है ज़माने में viral hepatitis और NASH के सिवा. So for that, for our first talk, which is about Wilson's disease, diagnosis and management, I would like to call upon Professor Dr. Shahid Sarwar, who is also Professor of Medicine and a competent researcher working in Jinnah Hospital, Lahore. Sir, kindly come and give us your views.
Thank you very much. I'm extremely honored and thankful to organizers for giving me opportunity to be here. And it has been a very excellent learning experience for me over the last 2 days. So my job in next 20 minutes will be to talk about, briefly to talk about the clinical manifestations, because that is an important part of the diagnosis, and then to see how we should diagnose patients of Wilson's disease and what are the treatment options that we have available for this disease. This is a disease which we know affects equally males and females, except for the fact that in older age groups, probably the males are a bit more affected by the Wilson's disease. Then the age range is very broad. The Wilson's has been diagnosed at the age of 3 years, and it has also been diagnosed at the age of 74 years. But most of the patients are diagnosed between 15 to 35 years, and hardly 3 to 4% patients are diagnosed after the age of 40 years. Another important thing over here to see is how do these patients present. You can see if disease is diagnosed at an earlier age, the first presenting complaint is more likely to be related to the liver. But as the age progresses, in older age, the diagnosis generally comes from neurological manifestations more likely as compared to the hepatic manifestations. Basically, it's a genetic disorder, and which is characterized by ATP7B mutation on chromosome 13. And this particular gene is responsible for production of a protein, which is Wilson ATPase protein. And we'll see what it does and what function which is lost lead to this particular disease. The problem with this mutation is it's a very complex mutation, and more than 800 mutations have been identified. And this is one issue that we will see that hampers the genetic testing of the patients of Wilson's disease. So it's an autosomal recessive, and there is a high risk in first degree relatives as compared to the second degree relatives. So Wilson ATPase is the protein which is produced by that particular gene. It has two functions within the hepatocyte. One, it takes up the copper which has entered into the cell and incorporates it into apoceruloplasmin, and converts into a holoceruloplasmin, which is the one which is going to be released into the circulation. It has another function, and that is when the copper is excess within the hepatocytes, it is also responsible for excretion of copper into the bile. So what happens if somebody gets mutated? there are two possibilities. Either this protein is not produced, or there is some deformity like misfolding, which leads to non-functioning of this particular protein. Or the other thing can be some physiological issue, it's a functional defect where it fails to bind to the Golgi network properly and resulting in failure of its function. So if copper is not being handled by this protein, that will start entering into the mitochondria of the cell, that will lead to the damage of the liver to the liver. But that's not the only effect of this deficiency of this particular protein. Once the copper is excess within the cell, it will start releasing into the circulation. And once it is into the circulation, it can affect other organs as well. And that's what is responsible for extrahepatic manifestations of Wilson's disease, because then it can affect the brain, then it can affect kidneys, then it can affect the different organs as well. So Wilson's is basically a multi-system disorder which can have varied clinical manifestation, but predominantly the two organs which we all know is either the liver or the brain which is affected by this particular disease. How do the patients with liver disease manifest? It can vary from asymptomatic to acute liver failure. Patient may be diagnosed just because of deranged LFTs, may be diagnosed because he's undergoing screening because there is a family member there with Wilson's disease, or patient may be diagnosed with end-stage liver disease, with liver cirrhosis, and there are few patients which will be first-time diagnosed with acute liver failure. Now that is something which needs particular mention here, because the survival without transplant in somebody coming with liver failure is not possible. It's almost 95% mortality is there if the first diagnosis is at the stage of acute liver failure. What about neurological manifestation? Again, there is a broad spectrum of manifestations. It can be akinetic rigid syndrome, just like people who suffer from Parkinsonism. It can be pseudosclerosis leading to tremors, which are called wing beating tremors. Then patients can have ataxia, dystonias. But the most important to remember and recognize is the psychiatric manifestations. Patient may start with poor performance in the school, impulsiveness, mood changes, personality changes, inappropriate behaviors. And these are the manifestations where the diagnosis will be very late, because most of these patients will continue with psychiatric medications till somebody comes up with the possibility that this can be a Wilson's disease. So neurological manifestations are much more crippling. Just to give you an idea what sort of manifestation is this. This is dystonia. And you can see patient is rigid, he has got tremors. Most of these patients end up being bedridden. They are unable to perform, they are unable to eat, and they have difficulty in chewing, swallowing, talking. All these functions are lost in these patients. Now this is typical wing beating tremors. And you can see why these tremors are called wing beating tremors. Apart from liver and neurological manifestation, we all know the patients can have these KF rings. This is the deposition of copper behind the descendant membrane, and it can be diagnosed by the slit lamp examination. Then there are so many organs which can be involved. There can be renal manifestation, musculoskeletal involvement can be there. It can affect the heart as well, leading to cardiomyopathy and arrhythmias. Patients can have difficulties with fertility, like amenorrhea, ovarian dysfunctions. So we need to remember all these atypical manifestations as well, because that will help in early diagnosis of this disease. And earlier you diagnose, the better is the outcome in these patients. So let's talk about how to diagnose. The one thing we need to remember, there is no single test which can give you the diagnosis of Wilson's disease. There is a list of tests that we are all using: ceruloplasmin, 24-hour unicopper, free copper, KF rings. But all of these tests have limitations that we are going to see briefly now, one by one. We know ceruloplasmin is a very good test, and the levels less than 0.1 gram per liters are generally diagnostic. But patient can have false negative results in acute phase reactant, and in pregnancy these results may be normal even in a patient with Wilson's disease. Then patients of malabsorption, protein lossing enteropathy, and all acute phases of disease may be having normal ceruloplasmin levels, may be having this low ceruloplasmin levels despite there is no evidence of Wilson's disease. So it has a very poor positive predictive value, and it may be normal in 15 to 36% of patients with Wilson's disease. What about serum free copper? It's basically calculated from total copper by subtracting the copper which is bound to the ceruloplasmin, and more than 200 microgram per liter is suggestive of Wilson's disease. But it has its own issue. How are you testing for ceruloplasmin? How are you checking for serum copper? So there are limitations attached to this particular test as well. Then 24-hour urine copper, we all know value above 100 milligram per 24-hour is mostly diagnostic. Even above 40 is considered as suggestive. But there are issues with collecting a urine for 24 hours. Then you have to use the utensil which is not contaminated with copper. Then this value may be raised in patients with acute autoimmune hepatitis, cholestatic diseases. So you may find normal values of 24-hour urine copper in patients who are asymptomatic. So these are again the limitations which hampers this test from being the gold standard test for diagnosis. D-penicillamine challenge test is basically giving penicillamine and checking the urine for next 24 hours. Problem with this test is that it is only standardized for children, not for the adults. What about liver biopsy? The gold standard in most of the diseases. But there is no one histological feature which is specific to the Wilson's disease. So the next option will be specific staining for the copper. But those stains are basically checking either metallothionein or lysosomal copper complexes. So this basically is an indirect test. And you can only diagnose around 15 to 20% patients with liver biopsy if you are just focusing on histopathology and special staining. That's why it is recommended that you always advise this dry copper content in the liver biopsy. That above 250 microgram per gram of liver is suggestive. But again, there are issues with this test as well. You need to have at least a sample of 1 centimeter size. Then the heterogeneity of distribution of copper within the liver. So maybe the area which has been used for biopsy, maybe the content is not that high. That can be the problem. And this test can also be negative in patients with Wilson's disease in around 15 to 20% patients. So you see, every test has its limitations. So there has to be a way, how are we going to use this test to make the diagnosis? Then what about genetic testing? I've already told you that more than 500 different mutations are there. So it will be practically impossible for going for genetic testing in every patient. There is one which is more common. And usually you do perform genetic testing for patients of Wilson's disease because that helps in family screening. So there are new ways of going for genetic testing which are better and more practical and which can lead to diagnosis. But still, we don't have one specific test for this. So that's the solution for diagnosis. And this particular scoring system, Leipzig scoring system, is there for last 20 years. So how do you use that? There are multiple parameters. First, you'll talk about the clinical parameters. That is the presence of KF rings, neurological manifestations, serum ceruloplasmin level, and presence or absence of hemolytic anemia. So first we will test for these 4 things. 2 are clinical and 2 are basically biochemical parameters. All you need to complete is you have to get the score of 4. If you can get 4 score with this, only these 4 parameters, the diagnosis is final. That means if somebody has KF rings and his serum ceruloplasmin level is below 1.2 grams per liter, the diagnosis is final. But if the score is between 2 to 3 or 0 to 1, then you will have to go to 24-hour urine copper. And if that test is positive and that makes the score 4, your diagnosis is stopped here. You don't need to do it further. But if somebody with 0 to 1 score in initial 4 parameters will not get 4 score even with 24-hour urine copper. These are the patients where you will go for liver biopsy. So there, and in liver biopsy, you are going to look for dry weight of the copper in that. Even if you can't get the 4 score from here, then you will go for the genetic testing. So that is one particular way of diagnosing, which is recommended by EASL, which is recommended by European Pediatric Gastroenterology Association to be used, and it has shown very good sensitivity and specificity in diagnosing Wilson's disease. What about treatment? There's a lot of talk about dietary restrictions, what to eat, what not to eat, but there is no randomized study and there is no solid evidence to suggest that dietary restriction does help. But obviously, well, normally you take 2 to 5 grams, whatever normally we are taking 2 to 5 milligram per day is the consumption of copper, and out of that 40 to 70% is absorbed. So it is understandable if we reduce the dietary intake, there are less absorption of copper, there is less chances of damage to the liver. So it's always useful to guide patients regarding this. But this, so generally recommended copper intake for a patient with Wilson's disease is 1 to 2 milligram per day. But in somebody who is strict vegetarian, this will become a problem, because then he will end up with protein malnutrition, because then the content of the protein that he is going to take daily will be diminished. So this particular dietary advice has to be used carefully according to the culture and the dietary habits of the patient. What about the drugs? These are the drugs which we are using for last 2-3 decades. And unfortunately, there is no addition to this. Because if some drug has to be added to this, that has to perform better than penicillamine and zinc. So right now, you don't have any other medicine, newer drug, which is in pipeline, in phase 3 trial, which has shown better performance. So still the drugs are the same. Penicillamine is basically a chelating agent. It is responsible for mobilizing copper from the tissue into the circulation, and it promotes excretion of the copper into the urine. You start with 500 milligram, build up the dose up to 1500 milligram. You don't take it with the meal. It is either 1 hour before or 3 hours after the intake of meal. It is very effective for hepatic manifestations, but its efficacy in neurological manifestation is not that good. It's around 55%. Then there is a risk of worsening of neurological manifestations with it as well, because it increases the serum copper level, because it mobilizes the copper from the tissue. So that's a risk that you run in patients where you start with the penicillamine. Then the solution is to start from a lower dose, 125 milligram, and then build that incrementally, keeping an eye on the neurological and clinical status of the patient. What about trientine? It's again another chelating agent. It's an alternative to penicillamine. If somebody is resistant to penicillamine, this is the option which can be given. Again, it's basically, it has lesser neurological deterioration with its use as compared to the penicillamine. So this can be used if somebody is unable to tolerate, because there are side effects associated with penicillamine. What about zinc? It works totally differently. It basically reduces the absorption of copper from the intestines. So it induces metallothionein in the enterocytes as well as in the hepatocytes. So there are different forms, acetates, sulfates, and gluconates. And the dose, we all know, it's 150 milligram per day that we give in divided doses. It's not very good for induction, because giving it as a first treatment, there is a risk of hepatic manifestations getting worsened, because it's not going to mobilize copper from the tissue. So it's generally used for the maintenance phase, where because it's cheap, because it's well tolerated, and it has good efficacy, and it can be used for a long time. In those who are asymptomatic at the time of diagnosis, this can be the choice to start with. And we monitor all of these drugs with urinary copper. That gives us a very good idea that either we should increase the dose or decrease the dose. And it also gives you a very good idea whether the patient is compliant to the treatment or not. So you can always modify and adjust and reinforce compliance based on the urinary copper of the patient. And don't forget to check for side effects, especially if you are using penicillamine. You have to check for CBC, LFTs, and urinary protein. And obviously, the interval of checking goes on increasing if the patient is able to tolerate it in initial 1 to 2 months. So bottom line is that there is an induction phase, and then there is a maintenance phase. Induction phase, you would like a chelating agent, but do remember there is a risk of neurological worsening there. And in maintenance phase, zinc is the option because of the so many benefits that you get with the use of the zinc, as far as the cost, as far as the tolerability, and all these things are concerned. What is new in Wilson's disease? There is talk about vitamin E, there is talk about there are the copper transporting agents, but the problem with all these new drugs is that their efficacy is not as good as the drugs which are presently being used. So that's why we have not seen any new drug coming up for last so many years. Probably being a genetic disease, this is the future for Wilson's disease. And there are a number of studies on animal models which have been published, which shows that this particular treatment, this liver targeted gene therapy has shown efficacy in animals. And last year, this particular gateway trial was approved by FDA. They had received a fast track approval for this trial. This is a phase 1 to 2 trial, primarily meant for safety, but they have also focused on that they are going to see its biochemistry and its excretion and its effect on the liver function as well. And they have planned to incorporate 16 individuals for that. What they are going to do is that they are going to give one intravenous infusion of this adeno-associated virus vector, which is basically a single-stranded DNA genome. And it is going to translocate a shortened version of ATP7B. And the results are still awaited. Probably this is the solution for majority of diseases which are genetic. Few words about acute liver failure, because it's a total different situation if you face a patient of acute liver failure with Wilson's disease. Because if the patient is in encephalopathy, he's not going to survive without liver transplant. You may try chelating agent if patient is not in encephalopathy, but there is a time limit to that. 1 week will be the time where you will decide whether to go for transplant or not. So people have tried this MARS and plasma exchange therapies for patients with acute liver failure, but remember, these are the bridge therapies. These are only meant to take the patient to the liver transplantation. And there are predicting scores as well. This is new Wilson score, and they have shown that somebody has score more than 11, or there is no chance of survival without liver transplant. That should be decided immediately on arrival of the patient. What about family screening? First degree relatives of all patients of Wilson's disease, they should be screening. Genetic testing of ATP7B, that should be carried out if we know the mutation in the index case. If that is not known, then there is new way of doing this genetic testing by pedigree analysis using haplotype based, using common polymorphisms which are there. A AASLD has allowed, if you don't have genetic testing, you should check with CBC, LFTs, ceruloplasmin, 24-hour uric copper, for siblings if this testing facility is not available. So in summary, Wilson's is a complex heterogeneous autosomal recessive genetic disorder, and it's a multi-system it has got multi-system clinical manifestations. Diagnosis needs systematic approach, as we have seen how we are going to use our test for diagnosis to make it cost effective and meaningful. Treatment is lifelong, and the focus is on removing the copper from the tissue and then not allowing copper to get absorbed from the intestines. That is the only solution we have right now for the patients of Wilson's disease. And probably the gene therapy is the one which is the future of the Wilson's disease. Thank you very much.
Thank you, Dr. Shahid Sarwar, for a nice, comprehensive talk.